Good evening friends, welcome to my channel Critical Care Basics, and as you all know we are running ECG tutorials in this channel, and this is the 40th ECG tutorial. In the last tutorial we discussed about part 1 of the approach to diagnosis of wide complex tachycardia. We will continue this lecture today and discuss about few algorithms that help us to diagnose a wide complex tachycardia as to whether it is VT or supraventricular tachycardia. So let's begin. Approach to diagnosis of wide complex tachycardia part 2. What we saw in the last lecture to suggest VT as a wide complex tachycardia, just recapitulate few points. First is in lead V1 we have to see for the morphology of the wide complex tachycardia whether it is LVBB type or RBBB type. Second point is we see the axis. If the axis is northwest, it is likely to be VT. There are two exceptions. One is antidromic AVNRT and second is biventricular pacing. Third is we saw about the rhythm. When the rhythm is regular in wide complex tachycardia, that favors VT. We saw about the QRS duration. The more the QRS duration, more likelihood of it being a VT. We saw the concordance. If there is concordance, it is more likely to be ventricular tachycardia. And lastly, AV dissociation is very important. If you see AV dissociation, that practically clinches the diagnosis of ventricular tachycardia. So having seen all these points, there are few further signs that we'll talk about before going to the algorithms. If the tachycardia is RBBB type, right? And you have the first habit in RBBB type, you have RSR prime pattern. RSR prime pattern. So these are two waves. But in ventricular tachycardia, if it is ventricular tachycardia, the left rabbit ear is taller than the right one. If this is the case, it is likely to be ventricular tachycardia. While in RBBB, the right rabbit ear is taller. This is the most specific finding in favor of ventricular tachycardia, right? Second is Brugada sign. The distance between the onset of R wave to the nadir of S wave is more than 100 milliseconds or small 2.5 squares. So the onset of R wave to the nadir, that is the deepest point of the S wave. If it is more than 2.5 small squares or 100 milliseconds, that is called Brugada sign. That suggests that this is ventricular tachycardia. If you do not see classical R, you can measure the onset of R wave from this point to the nadir of S wave. Another sign is Josephson sign, notching or slurring near the nadir of S wave. So near the nadir of S wave you see a small notch. If this is seen, this is Josephson signs, again suggestive of VT. You can also see Brugada sign here from the onset of R wave to the nadir of S wave. It is practically more than 4 small squares or 160 milliseconds. This is highly suggestive of ventricular tachycardia. Now having said that, there are few algorithms. The most widely accepted one is the Brugada algorithm. So no algorithm is perfect, but it has a high sensitivity and specificity to diagnose VT. There are 4 steps in this algorithm. We will walk through this algorithm. First we'll have a cursory look and then go detail into this algorithm. The first point that you have to see is absence of RS complex. This is the RS complex, right? So the absence of RS complex means that either it is positive or negative. That means if it is positive in all chest leads, then that is positive concordance. If it is negative in all chest leads, that means negative concordance. So absence of RS complex means that there is concordance. So if there is concordance, then it is likely to be VT. The sensitivity is 0.21. Sensitivity is slightly less, but the specificity is good, 1. If there is no concordance, you go to 0.2. 0.2 is nothing but the Brugada sign. R to S interval more than 100 millisecond. If even it is seen in only one precordial lead, that is enough. If it is yes, it is sensitive as well as specific for VT. If Brugada sign is also negative, the third step that to see is whether the patient has AV dissociation. Like you have to see QRS complexes more in number than the P waves, there is P dissociation and PR intervals are changing. So all these signs, capture beats, fusion beats, all these signs if you see and diagnose AV dissociation, that is highly specific, sensitivity 0.82 and specificity 0.98, it is very likely to be a ventricular tachycardia. If AV dissociation is also not evident, then there are certain morphology criteria that are different for RBB type white complex tachycardia and LBB type white complex tachycardia. If these criteria are met, there is high sensitivity and specificity of it being a ventricular tachycardia. While if these criteria are not met, then probably it could be supraventricular tachycardia. We will walk through this algorithm again. So step 1 is to see for absence of RS complex in all precordial leads. This simply means that there is concordance. So if you see concordance, like this is negative concordance in all lead V1 to V6, you see a QS pattern. So this is negative concordance. Here in all lead V1 to V6, you see a positive RS complex, R complex. So this is positive concordance. So if this type of ECG is seen, it is likely to be VT. The sensitivity is low, but the specificity is high. In this ECG, there is no concordance. There are QS pattern here while R pattern here. So there is no concordance. If there is no concordance, then you go to step 2. So step 2, what is step 2? It is just the Brugada sign from the onset of R wave to the nadir of S wave. If it is more than 100 milliseconds or 2.5 small squares, then that is suggestive of VT, sensitivity 0.6 and specificity 0.98. In this ECG, you can see that probably you can say this is the origin of the R wave and this is the nadir of S wave. So this is less than 2.5 small squares. So Brugada sign is negative. This is white complex tachycardia. Then in that case, you go to step 3. What is step 3? AV dissociation. So if you see in this ECG, there are P waves that are regular, they are not associated or they are dissociated with the QRS complexes. QRS complexes are much faster. White QRS complex, there is no relation between P and QRS and the PR intervals are changing, while RR intervals and PP intervals are same. So you also see capture beat and you also see fusion beat. So once AV dissociation is seen, that is practically diagnostic of VT, right? Next, if AV dissociation is not seen, then we go to step 4. Step 4 has some criteria for RBB like white complex tachycardia and some criteria for LBB type complex LBB type white complex tachycardia. So let's go to these criteria. If the patient has RBBB like white complex tachycardia, then in V1 you have to have a complex something like this. So either you have to have a small q and tall r or monophasic r. So either you have to have this type of monophasic r or small q and tall r, or if you have this type of r is not allowed, you have to have a taller initial r left trapezius and broad initial R wave. So initial R wave, this should be broad, more than one small square. So broad initial R wave, tall R complex and left trapezius. If there are two peaks, the left trapezius is taller. So these signs in lead V1 and lead V2, there should be either QS, or if R is present, R should be much smaller than S, or R by S ratio should be less than 1. You can see here the R wave is very small and the S wave is deep. So R by S ratio is less than 1. So if this is the case, this suggests ventricular tachycardia. If it is LBBB pattern, then initial broad R wave should be at least more than 30 milliseconds. If not, a small square is 40 milliseconds. So almost 3/4 of the small square, and RS interval should be at least 70 milliseconds. Brugada sign says that RS interval should be more than 100 milliseconds. Even if that is not seen, it should be at least 70 milliseconds, right? And R wave during white complex tachycardia taller than R wave during cynicism. So R wave, if you have an ECG of patient with sinus rhythm. So the R wave during the white complex tachycardia should be taller than R wave during the sinus rhythm in V1. Lastly, slow descent to the nadir to S. So you see Josephson sign. So any of these in or all of these in V1 or V2 plus any Q or QS complex. There is a QS complex in V6. So if these are met, then the patient has high likelihood of ventricular tachycardia. Sensitivity is as high as 0.96 and specificity as high as 0.98. If these are negative, then the patient will have supraventricular tachycardia probably. Another algorithm is Vericke algorithm. It has many points in common, but some points are slightly different, and it is important to know these signs as well. Vericke algorithm first points out to AV dissociation, right? So if AV dissociation is present, it is VT, almost certainly VT. If AV dissociation is not present, then initial R in AVR is present. So this is AVR lead. You see a tall initial R. And this usually happens when there is northwest axis. So this is tall R. Sometimes you see a small R followed by a tall R. So RS R prime pattern with a second R taller. This is more likely to be seen in SVT or in tricyclic antidepressant toxicity. While a tall R initially in AVR is highly suggestive of ventricular tachycardia. If this is also not seen, then initial morphology unlike bundle branch block or fascicular block. So if initial morphology is unlike bundle branch block or fascicular block, then it is likely to be VT. If this is also not seen, then VI by VT less than 1. So what is this VI by VT? So in same QRS complex, right, in multiphasic or biphasic QRS complex, you have to see for the initial 40 milliseconds or initial small square of the QRS and the terminal small square of the QRS, and see for the amplitude. Like this is the initial small square, initial 40 milliseconds, and the amplitude, this is called initial V amplitude, and here terminal 40 milliseconds, you see the amplitude here. If Vi by Vt is less than 1, then this is highly sensitive and specific for ventricular tachycardia. If these all signs are negative, then it may be supraventricular tachycardia. So this was the Vericke algorithm. The problem with these algorithms are they are slightly complex. So practically in an ICU setup, most of the physicians as well as even the cardiologists are reluctant to use these algorithms. So this was a simplified algorithm where you have to see only 3 criteria. The criteria 1 is the history, if the patient has MI or patient has heart failure with ejection fraction less than 30%, and or a history of ICD. So if any of this is present, then patient has criteria number 1. Criteria number 2 is to see in lead 2, first peak, time to first peak should be more than 40 milliseconds, right? So it should be slow onset VT. So time to first peak should be more than 40 milliseconds. Again, you see in lead AVR, the time to first peak should be more than 40 milliseconds. That is more than 1 small square. So if 2 or more of these criteria are present, this is VT, while only 0 to 1 criteria are present, this is SVT. So this is much shorter to be used, and many people prefer to use a shorter trick to diagnose. So this takes about 30 seconds to complete, while a Brugada algorithm will usually take about 2 minutes. The problem is above algorithms do not work in patients with accessory tracts, with pre-excitation, especially with antidromic AVRT. So whenever there is WPW pre-excitation and antidromic AVRT, these algorithms will not work. So they have designed a special algorithm for patients who may be having WPW syndrome. Either they have delta wave somewhere in their early ECGs, or there is high probability of WPW. For the patients who have WPW syndrome, or there is a suspicion of WPW syndrome, pre-excitation or antidromic AVRT, they have designed a special algorithm that is different from the Vericke and the Brugada algorithm. The first thing that you have to see is predominantly negative complex in V4 to V6. So you have a wide complex tachycardia, and the first thing, if you suspect AVRT, antidromic AVRT, then see for negative Q waves in V4 to V6, predominantly negative complex, either QS or QR, but the R should be smaller, S should be larger. If it is present, the sensitivity is 0.6 and specificity is 1, that it is ventricular tachycardia. If it is not there, at least presence of QR complex in one or more precordial lead. Predominantly negative complex in V4 to V6 are not there, but even in one lead from V2 to V6, you have large Q and R complex. So if that is present, it is almost certainly VT. Very high sensitivity 0.75 and specificity 1. If it is also absent, then C for AV relation different from 1:1, that is whether there is AV dissociation. So if there is AV dissociation, it is certainly VT. Again, sensitivity of 0.75 and specificity of 1. If you do not see any AV dissociation, then it could be either SVT or VT, you don't know, probably antidromic AVRT. So you require a ECG during the sinus rhythm or probably an EP study. Now this is a wide complex tachycardia. What you easily see is the irregularity. So rate is very high and it is quite wide and irregular. What you also notice is the initial first wave is a narrow complex wave. Here you do not see P wave, so it is a narrow complex wave initial, and in this lead you see a delta wave. So what does this suggest is this could be atrial fibrillation with WPW syndrome, and this patient was cardioverted, and now you see a narrow complex tachycardia. So here because it is AF, you do not see P waves, but something like P waves somewhere you see. So probably this is supraventricular tachycardia, and this is irregular, so this is AF with AVRT. Another wide complex tachycardia, what do you see in AVR? AVR, you have second rabbit ear that is taller. So normally the first rabbit ear should be taller to call it VT in as per Vericke algorithm. The second rabbit ear in AVR, R prime is taller. So the axis is northwest. So northwest axis could be VT, but it could also be antidromic AVRT. So we do not know. This patient was hemodynamically unstable and he was cardioverted. After cardioversion, you see sinus rhythm, but you do not see classical delta waves. There is small suspicion of a pre-excitation here, but no classical delta waves. So post cardioversion echo was done and echo showed a good LV function. So he was referred to a cardiologist and probably he thought it was AVR, antidromic AVRT. The electrophysiologist noted where good LV function means that this is if it is VT, it would be likely to be idiopathic VT. But to call it idiopathic VT, it should have a rapid onset. Here the onset was slow. So this has a slow onset, and it is unlikely to be either type of VT. So finally, had it been RV outflow tract VT, which responds to adenosine, LBB, it should show LBB morphology with inferior axis, but here it was RBB type pattern. And lastly, therefore it was AVRT is most likely, even though there were no delta waves. Sometimes there is only antidromic or reverse conduction from the accessory tracts. So even if you do not see delta waves, patients could still have antidromic AVRT, and to diagnose that you require a EPS. Thanks a lot for being with me. This was the part 2 of the lecture on diagnosis of wide complex tachycardia. I hope this is going to help you in your clinical practice. If you're liking these videos, please like, subscribe and share. Bye bye.